As you can imagine, in the sarcoma world, there's always controversy, and
Sure.
I think one of the big controversies that is more settled now. I think is choice of therapy in the first line metastatic setting. There are different schools of thought as far as using a combination of drugs versus single agent drugs, and so the use of doxorubicin and ifosfamide and mesna as a first line therapy, while it does have a better response rate and a slightly better PFS, there's no significant difference in the overall survival rate compared to doxorubicin alone. My approach previously to the approval of olaratumab had been primarily to give, in the setting where patient is really not that symptomatic, I would give single agent doxorubicin by itself. I personally would reserve the use of adriamycin and ifosfamide in the use of a patient that's metastatic if we need to get a response quickly, and if they're quite symptomatic from their cancer. Do you use adriamycin and ifosfamide at all in your treatment as well?
So Adria, ifos, and with mesna, of course, is a reasonably toxic regimen. I mean, ifosfamide has to be given inpatient, and it's just there's so many logistical constraints on using ifosfamide that generally for many of the gynecologic cancers broadly, it has slowly kind of fallen out of favor. We used to use ifosfamide for carcinosarcomas, and that's also still standard of care. I mean, we're not disputing that, but it's also, we have other regimens that we've kind of moved away from. So we're using a lot more single agent Adria, I think, kind of as data has come out for that, simply because the toxicities of Adria ifos are just, they're pretty impressive. At least in our experience or in my experience, they're fairly impressive. So, I think using other doublets though, such as olaratumab, I think, kind of has made just the armamentarium that we have for sarcoma treatment much bigger.
As you know, the Lancet paper was a phase 2 study with doxorubicin alone versus dox plus olaratumab. It changed overall survival, the median overall survival from doxorubicin alone to 14 months to 26 months. So I think if that is confirmed in the phase 3 study, which has already filled accrual, and hopefully we'll have data out within the next year and a half, in 2018, 2019, I think it's going to change their approach, frankly. The big question, I think, for that combination is the response rate.
Right.
If the response rate approaches a similar response rates to adriamycin and ifosfamide, that may be the point where we actually get rid of it. And so the way using adriamycin and ifosfamide early on does affect my ability to treat them differently, frankly. There's no safety data yet in combining olaratumab with doxorubicin and ifosfamide together. Olaratumab we have seen in the combination study with doxorubicin, it does have a slightly increased risk of cytopenias. And so you can imagine adding the third drug with ifosfamide may be toxic, and so I think we don't know exactly yet how to treat it safely. But if that is safe, that may be also a very good opportunity as well for patients that actually have more aggressive disease that need a higher response. And so I think things are changing pretty rapidly here. So how often do you use gemcitabine and docetaxel in the first line?
Well, up until probably about a year ago, I was using it pretty much exclusively, because again, this is why I think collaboration is so important. I think for most of us in G1 oncology, we kind of were raised in the area of gemcitabine and Taxotere. So I was using it quite a bit, but as I've kind of done more collaboration with you and seen more data, we are certainly using more adriamycin. I think with the point that you brought up is kind of interesting is we have data of gemtax versus adriamycin, and we have data of adriamycin versus Olara plus adriamycin. And you shouldn't do cross-trial comparisons because those are two separate trials, but I think you raised the really interesting question is up front, should we be using Olara adriamycin? We don't have Olara adriamycin versus gemtax that I'm aware of, kind of head-to-head comparing those two to really come up with an answer. But I think that it does raise a lot of compelling questions. And I have used Olara adriamycin and had pretty impressive responses with that. I do think it is obviously a little bit more toxic than single agent adriamycin. And I'll be honest, I don't think I would be very excited about adriamycin, ifosfamide, and Olara as a triplet, because I think that would be quite toxic, as you said, for the reasons of the pancytopenia and the other issues that come along with adding ifosfamide to an already hard regimen.
There actually is a clinical trial now looking at gemcitabine and docetaxel combinations with olaratumab, both in the naive as well as pretreated setting for olaratumab, to see if continuation of olaratumab actually benefits patients
Sure.
with different lines of therapy. One of the biggest downsides for using doxorubicin in combination with olaratumab is the fact that we think that there's significant synergy between the two drugs. And so olaratumab alone has a very, very poor response rate, although we do think it has activity as a single agent. I have one of the patients we share has been on olaratumab single agent now for 30 plus cycles, and they had progressed pretty quickly
Sure.
on gemcitabine and docetaxel before. So
Right.
how we incorporate that into our treatments is going to be really important in the near future, and I think we're going to have more help to decide that.
Definitely.